Good evening to all the respected doctors present here. I, Dr. Snehal from the USV medical team, welcome you all for yet another interesting session in the CME India series. Today we have a very interesting topic with us, that is options for intractable painful diabetic neuropathy and vascular diseases. Without much ado, I would now like to introduce to you Dr. N.K. Singh, sir. Sir is the Director for Diabetes and Heart Resource Center, Dhanbad. He is the Chairman for RSSBI Jharkhand, Executive Member National RSSBI, ex-governing body member for National API, ex-Chairman API Jharkhand CCD SI He has also edited the Millennial Book for Medicine. He is the Associate Editor for the Postgraduate Medicine 2021. He has edited Monograph on COVID by ICT API 2023, has more than 40 publications in national and international publications to his credit. He is also the admin and founder for CME India. A warm welcome to you, sir, and I hand over to you to introduce our dignitaries for the evening.
Yeah, thank you, Dr. Snehal. So, can I have a slide of, today, I really welcome you all. And I think this is a very, very important topic we are going to discuss. So, we have got for the concluding remarks, Dr. Vijay Patni. I think you all know he is the HOD Diabetes Wellness Clinic, Kolkata, and he is doing lots of work, basically in the field of research of diabetes, and he have got many awards and achievement. And next, Dr. Singh, he is the Senior Consultant Medicine, Diabetology, Non-International Cardiology at Baroda, Gujarat. He is the National, Regional and State Conferences invited faculty and speaker, many principal author of the many publications in international and Indian journals, reviewer. So welcome, Dr. Akash. And I have great pleasure for our expert panelist. I think Dr. Velu from Trichy, he is a consultant physician, diabetologist. Now the chairman, academic RSSTI Tamil Nadu chapter. Past secretary, as you see, from the Tamil Nadu chapter 2017 to 21, and served in the Tamil Nadu Medical Services, and regional faculty of the Public Health Foundation of India, published articles in various journals, honored with Professor Dr. Sam J.P. Moses Soresan Award. So I think he's a great person. And now I hand over this stage to Dr. Velu to introduce to our learned speaker of today. Thank you very much. I welcome all the audience as well.
Thank you, Dr. N.K. Singh. Very pleasant evening. My hearty welcome to all the viewers and listeners of this program. Respected editor, CME India, Dr. N.K. Singh, members, other members of the panel. It's my great privilege and honor to introduce our guest speaker of this day, Dr. Ramnarayan. He is a consultant functional neurosurgeon, invited speaker in many international neurological meetings. He has to his credit several publications in international journals, awarded the Gold Plaque by the National Neurosciences, Achievers Award and Gold Medal by the National Integrity Academy, Chennai, for his work on developing awareness. Next is conferred the IFAANS, that is International Fellow of American Neurological Surgeons, currently engaged in doing epilepsy surgery, recently awarded the Vocational Excellence Award and his website. So I thank each and every one each and every one of our viewers and listeners for taking your valuable time to attend this meeting. So let me set the initial context. I'm sure all are aware about William Osler. He has said once, who understands pain knows medicine. And yet another, Paul Brand, he has also conveyed pain, God's greatest gift to mankind. Neuropathy is a common complication of both type 1 as well as type 2 diabetes. It may be present in 10% of the newly diagnosed type 2 diabetes, which accounts for major cause of morbidity and increased mortality. Of course, symptoms are not a reliable indicator for the severity of the nerve damage. Recent studies suggested that unmyelinated C fibers are damaged early. And if you look into the definition of diabetic neuropathy, it conveys presence of symptoms and or signs of peripheral nerve dysfunction in patient with the diabetes after the exclusion of other causes. Of course, absence of symptoms cannot be equated with absence of neuropathy, as asymptomatic neuropathy is very common. So, in short, there is a symmetrical, length-dependent sensory motor polyneuropathy attributable to metabolic and microvessel alterations as a result of chronic hyperglycemia and cardiovascular risk variants. Of course, we have certain modifiable risk factors, non-modifiable risk factors, and if you look into the pathogenesis, diabetes can result in metabolic changes, hemodynamic changes, structural changes, and functional changes with reference to peripheral nerves, dorsal root ganglion, in the spinal cord, as well as in several portions of the brain, namely the sensory cortex, hypothalamus, amygdala, etc. Wherever it produces lesions, it is characterized by ectopic impulse generation, number one. Very important thing is there is increased excitability, what we call it hyper excitability. There is a reduced threshold for the pain, and there is increased magnitude of response to noxious stimulation that results in severe painful neuropathy. And regarding the management of neuropathy and screening, I'm sure most of the viewers they know from bedside diagnosis up to their nerve conduction studies. Regarding the management, glycemic control remains mainstay. That is, prevention is better than treating patients or seeing patients with the complications of neuropathy. And we have galaxy of drugs, first line agents, second line agents, third line agents. These are all recommended by the leading associations, both international as well as our own national guidelines, namely APA guidelines, as well as RSSDA guidelines. And very important thing is there is one condition called intractable painful diabetic neuropathy, refractory pain, where despite using 3 or 4 drugs together for a longer period of patients, patient may fail to respond to the therapy, naturally forcing us to go for some other alternative treatment. For this, I invite our guest speaker, Dr. Ramnarayan, to take all of us through his presentation on the intractable neuropathy management, that is options for intractable painful diabetic neuropathy and vascular disease. Over to you, sir.
Thank you. Thank you, Dr. Shunmugavelu. Let me start by thanking my good friend, Dr. Singh, to give me this opportunity to talk to such an august audience. As you correctly said, diabetic neuropathy is a very common problem, but occasionally I'm sure all of you in your practice see patients who are really intractable and who are really crying with pain. And I would be happy to shed some light on some of the recent advances, especially the surgical advances, which are now available in our country, where these people can be given some good pain relief as well as having a good quality of life. Thank you again for the opportunity to give me the talk, and let me start now. As Dr. Shunmugavelu introduced, I'm basically a neurosurgeon, but I've been focusing on what is called restorative or functional neurosurgery. So what is this functional neurosurgery? That is, as you all know nowadays, all the specialties are becoming bigger and bigger. And so in neurosurgery also, there are a lot of subspecialties like vascular neurosurgery, pediatric neurosurgery, all that. Restorative or functional neurosurgery is that subspecialization which deals with the surgical treatment of functional disorders of the brain. That is, the brain is a very funny organ because there are so many situations where that there is the patient is having symptoms, but the brain investigations are all normal. For example, classical example is an epilepsy. A good number of patients, I'm sure many of you see, the patient is having epilepsy, but the scans are normal, the MRI is normal, the EEG is normal, but patient has epilepsy. Again, I'm sure at least some of you have heard of the somebody having severe head injury on ventilator, no response, no pupils dilated and fixed, but the patient is CT scan is normal. Again, I'm sure at least some of you must have heard of the stories when somebody falls down, is normal, but just gets a CT scan just for the to be on the safer side. They find a large brain tumor which has been growing for a long time. So the brain is very funny in that the structure and the functions need not always go together. So that is why the importance of functional neurosurgery has come into the picture. In restorative functional neurosurgery, basically we do 5 types of surgeries. One is called deep brain stimulation, where we put electrodes into the brain of various regions for various conditions. The common conditions which we operate include movement disorders like Parkinson's disease, psychiatric problems like the OCD, depression.
Dr. Ramnarayan, little louder, please. Little louder.
Sure. Sorry. Intractable addiction. Is it okay better now? Hello, is it better now? Yeah. Chronic pain.
Yes.
Chronic pain, especially the chronic, the central post-stroke pain, the Guerin-Roussy syndrome, the thalamic syndrome, and all that. Intractable epilepsy, intractable obesity, especially the failed bariatric surgery. I also do surgery for aggressive behavior or self-harm in autism children. And as nowadays, schizophrenia also is slowly coming into the picture for surgery. The second surgery I do is intrathecal pumps, where there are 2 types of pumps commonly used. One is a morphine pump, which is used for all types of severe chronic pains like cancer pains. Here, the chronic pain actually is the noxious pains. So noxious pains, we use intrathecal morphine pumps like cancer pumps, failed back syndrome pumps, chronic pancreatitis, rheumatoid arthritis, severe pain, those type of conditions. And we also use intrathecal baclofen pumps, where the pump is filled with baclofen, and this is delivered into the CSF, and this is used for spasticity due to various causes like spastic hemiplegia, paraplegia, all these conditions, and patients in persistent vegetative state, also in cerebellar involvement, case of spinocerebellar degeneration or cerebellar involvement in multiple sclerosis. The third surgery I do is what's called spinal cord stimulation, and this will be the topic of our discussion today. This is indicated in intractable diabetic neuropathy pain, failed back syndrome, refractory angina or cardiac failure, complex regional pain syndromes, peripheral vascular disease pain, and so many conditions like that. The other surgeries I do include sacral nerve stimulation for bowel bladder involvement, epilepsy surgery including temporal lobectomy, and also vagal nerve stimulation for refractory epilepsy and also refractory treatment-resistant depression. Yeah, next one. As I said earlier, chronic pain is defined as any pain that lasts or occurs for more than 6 months or longer. Well, we know there's a nociceptive and there's a neuropathic pain. 30% of the people in the world suffer chronic pain, and out of this, 20% is neuropathic. Neuropathic pain is a result of tissue injury or nerve damage. Approximately 40 to 50% of neuropathic pain is caused by diabetes, and it is usually presents with burning or stabbing pain with associated numbness and tingling sensations. I saw an article in this journal, Indian Journal of Community Medicine, which says that the estimate of diabetic peripheral neuropathy prevalence in India is from 9.6 to 78%. As we all know, if left untreated, causes a lot of damage, including sensory damage, leading to insensate feet, which can end up in infection, ulceration, and finally amputation. Diabetic foot disease is a serious complication, and patients with the diabetes has a 25% lifetime risk of developing a foot ulcer, and between 14 and 25% of patients require a major or minor amputation. It's all quoting various journals. Then, of course, this is a classification of neuropathy, generalized neuropathy, focal neuropathies, and multiple focal neuropathies, which Dr. Singh already mentioned. And for peripheral vascular disease, we use the Fontaine classification, stage 1, 2, 3, and up to stage 4, which is the necrosis and gangrene of the limb. This diagram is very important because this is what is called as a WHO analgesic ladder. This analgesic ladder was introduced by the WHO in 1996 for treatment of chronic pain. Of course, that time they introduced it initially for cancer pain, but then they used it for other pains also. So in the first step, you always use the over-the-counter pain medications. If that doesn't work out, you go to higher NSAIDs, nerve blocks, and all that. If this also doesn't work out, you go to higher procedures, including opioids and thermal procedures. Usually 80 to 90% of the patients will have good pain relief by the third step. But there are 10 to 15% of patients who always will need still higher methods. And these higher methods are usually surgical and neurosurgical. The common higher methods used include neurostimulation and implantable drug pumps, and also deep brain stimulation. Intrathecal drug delivery systems can deliver drugs like morphine, baclofen directly into the intrathecal space. which they act on directly on the receptors in the spinal cord. They are very effective in noxious pains. Spinal cord stimulation involves placing electrodes dorsally in the extradural space and attaching it to a battery subcutaneously. This battery then stimulates the electrode to produce the desired effects. Currently, USFDA is approved for several systems, including failed back syndrome, intractable low back pain, complex regional pain syndrome, and other neuropathic pains. In Europe, it is approved for refractory angina and peripheral vascular disease pain. On January 24, 2022, FDA approved stimulation for treating chronic pain resulting from refractory diabetic peripheral neuropathy. So this is the left side, you see the pump. Of course, I'm not going into the technical detail because it's not our topic of discussion today. This is a spinal cord stimulation, which we use various times, depending on the size of the spinal canal, we can use whichever we need. And this is a battery which generates the energy required to stimulate. The spinal cord stimulation, as I mentioned earlier, it is indicated that these are various indications. And we'll be talking about spinal cord stimulation for intractable diabetic neuropathy pain. The contraindications include, of course, local infection, anticoagulant therapy, and it's a relative indication. And the most important is previous surgery or trauma that obliterates the spinal canal and epidural space. And a pacemaker is a relative indication. Major psychiatric problem and spina bifida also are relative indications. The complications are very few, where usually include infection, epidural hematomas, that is spinal epidural hematomas, CSF leak, spinal cord injury, and serious neurological complications are very rare. This is a relatively new technology that can help manage chronic pain where the cause cannot be removed or repaired. So that is very important, because if there is a primary cause which can be removed or repaired, that should be taken up, not the spinal cord stimulation. And many studies have also shown that it also helps in opening up the collateral circulation. And this is where it is very important, especially in severe diabetic neuropathy pain, because basically it is a microangiopathy. The mechanism of actions are: one is a gate control theory of pain, second is a supraspinal inhibition of pain, either by inhibiting pain transmission or modulation of pain impulses, blocking transmission in the spinothalamic tract, activating the central inhibitory mechanisms for influencing sympathetic efferent neurons, which will lead to vasodilatation and development of collaterals. This is what is useful in peripheral vascular disease, and activation of putative neurotransmitters and neuromodulators. So this diagram actually shows that, I have put the electrode here and I connected to a battery here, and I can produce pain relief of this pink shaded area. Suppose I want to make it both legs or both sides, I put it in the midline, then it can be this effect can be radiated to both sides. And the battery can be controlled by a system which is outside. We don't need to test the patient to control the battery. We can increase the current, decrease the current. So many other parameters can be adjusted like that. So indications of spinal cord stimulation in severe neuropathic pain. This is taken from this article. Neuropathic pain of more than 5 years and having failed multiple neuropathic medications or developing severe side effects due to the medications, as Dr. Shunmugavelu was talking in his introductional comments. The patient should have an HbA1c of less than 10, age 50 or less, but that I think is not very important. But age is a criterion, yes. The patient should have a 50% improvement in pain sensation following trial simulation. No severe depression or anxiety as other psychiatric symptoms. Patients should understand and accept the therapy, and patient as a course of psychological counseling. In peripheral vascular disease, the indications include modified ADA diabetic foot risk category of 2 and 3, preserved vibration perception threshold. This is very important, because if the vibration is not there, the spinal cord stimulation will not work. Ulcers not healing even after 12 weeks in spite of aggressive therapy, or ulcers recurring in the same site after healing once. When it is not possible to do open surgical or endovascular intervention with rest pain alone, with Fontaine 3, or rest pain and arterial ulcers, Fontaine 4. Or patients who undergone revascularization still in pain. Other conditions like vasospastic Raynaud's disease and all, and frostbite, this is a much better therapy than the vascularization, because again it's a peripheral disease. Some pictures here. This is one stimulator we have put in the lumbar area. This is a battery, you can see the connections. This is one put in the cervical area. just brush through some literature because there's not much experience about this surgery in India. So I didn't want to use the experience I've done outside India. So I'm just going through the literature. One is Journal of Diabetic Science Technology in 2024. Recent evidence indicates that SCS can provide safe and effective treatment for the pain from PDN, especially when lifestyle modification, non-pharmacological and pharmacological therapy all have failed. 10 kilohertz, that is high frequency SCS, has a better chance of producing good results. Another recent study, improvement in protective sensation. That is, as we already discussed, sensory loss is a major issue. But when during this stimulation with the spinal cord stimulation, people have found that the some of the sensations do come back. In fact, the one patient whom I operated had severe ataxia. And after the surgery, his ataxia disappeared so much so that he's able to stand for up to 20 minutes without any problem. In the study, the effects of high frequency paresthesia independent spinal cord stimulation was studied with, and the associated risk of foot ulceration was assessed. Participants in the 10 kilohertz group reported increased numbers of sensate locations as compared to CMM alone, that is medical management alone, and to pre-implantation, and were significantly more likely to be at low risk of foot ulceration. The proportion of significant improvements are observed in protective sensation from pre-implantation to 24 months post-implantation. With this unique disease-modifying improvement in sensory function, 10 kilohertz SCS provides the potential to reduce ulceration, amputation, and other severe sequelae of PDN. Diabetes research clinical practice. Where does spinal cord stimulation fit in the international guidelines for refractory painful diabetic neuropathy? Consensus statement. For appropriately selected individuals, again, this is very important, for appropriately selected individuals, because this surgery cannot be offered to everybody. So selecting the patient is a very important work of especially the surgeon and of course the diabetologist. For appropriately selected individuals, SCS is a safe, effective, and durable treatment option, especially the high frequency SCS. Another study, Journal of Management Care, I don't know what is that. Healthcare resource utilization and cost. Analysis from this trial indicates that the addition of 10 kilohertz SCS therapy results in lower rates of hospitalization and consequently lower healthcare costs among patients with diabetic neuropathy compared with those receiving conventional management alone. Pain medication 2023, same story, high frequency spinal cord stimulation alters sensory function and nerve fiber density in painful diabetic neuropathy. This prospective open label observation study, what they did is they studied the objective quantitative by the measured quantitatively the nerve pathology and patients underwent skin biopsies to measure intraepidermal nerve fiber densities and corneal confocal microscopic measurements before implantation and 3, 6, and 12 months after. Numerical rating scale of pain, visual analog score, neuropathic pain scale, and other assessments were also conducted. Significant pain relief was achieved at all follow-up visits. Neurological assessments with skin biopsy showed reduced number of absent responses and increased normal responses from baseline to 12 months. Both proximal and distal intraepidermal nerve fiber densities were higher at 12 months and baseline. Confocal microscopy measurements showed a steady increase in nerve density from baseline. Neuromodulation 2023, long-term evaluation. This is a study which was done over 8 to 10 years. And they found that SCS can remain an effective treatment in the long term to reduce pain intensity in patients who had this device implanted after 8 years. So up to 8 years, the device is still very effective. Pain medicine 2023, quantitative assessment of high frequency. This, of course, initially people are doing a very low frequency stimulation, but now we know the studies have shown that high frequency stimulation is far better, and the results are far much better. The 9 patients completed study and neuropathy impairment scores were improved, and 2 patients had recovery of sensory responses on nerve conduction studies. A reduction in sweat volume was observed in the proximal leg. Diabetes metabolism 2023, pharmacological, non-pharmacological treatment of painful diabetic neuropathy. The basic principle of management of painful diabetic neuropathy is to control hyperglycemia and other modifiable risk factors. Again, this was pointed out in the introduction remarks by Dr. Shunmugavelu. But occasionally, this may be insufficient. The US FDA has approved some drugs like pregabalin and other things. And recently it has approved the spinal cord stimulation for this condition. Diabetic research clinical practice, long-term efficacy. This is a 24-month results of a randomized SENSA PDN study. Totally 142 patients were studied. At 24 months, 10 kilohertz SCS reduced pain by a mean of 80%, with 90% of the participants experiencing more than 50% pain relief. Participants have significantly improved quality of life and sleep, and 65% demonstrated clinically meaningful neurological improvement. 5 patients had infection. That is about 3% is infection rate. This long-term data supports SCS as a safe and highly effective therapy. Pain physician 2022, improved sensation resulting from spinal cord stimulation. Sensory deficit, is a bigger problem in the diabetic neuropathy, and SCS might have unexpected benefits in patients with PDN beyond pain reduction. The SENSA PDN trial described improved sensation in association with SCS. Now we talk about a few literature on peripheral vascular disease. Comparative analysis of efficacy of spinal cord stimulation and traditional debridement care in the treatment of diabetic foot ulcers. This is a very recent publication. The primary endpoint was amputation, and other secondary endpoints are transcutaneous partial oxygen pressure, angle brachial index, and color Doppler lower limb arteries at 6 and 12 months. The dorsal foot oxygen tension and ABA of the patients in the SCS group were significantly improved at 6 months and 12 months post-surgery. The degree of vasodilatation of the lower limb arteries on color Doppler was higher in the SCS group. The odds ratio for amputation at 6 and 12 months postoperatively in the SCS group was 0.45 and 0.17 respectively, compared with the TDC groups. SCS improved symptoms of lower limb ischemia in ischemic diabetic feet and reduced the rate of toe amputation by increasing PtCO2, ABI, and arterial vasodilatation in the lower limbs. Neuromodulation 2023, comparison between efficacy of SCS and endovascular revascularization, a retrospective study. The patients in the SCS treatment group had a higher quality of life score, a larger reduction in pain scores, and a larger reduction in foot temperature, and degree of vasodilatation in the lower limbs on color Doppler. Nerve conduction velocity was higher in the SCS treatment group at 6 months. SCS was more effective than endovascular revascularization, improving quality of life, relieving pain, improving lower limb skin temperature, increasing lower limb blood flow, and improving nerve conduction in patients. ACTA Neurosurgery 2023, spinal cord stimulation in non-reconstructible critical limb ischemia, retrospective study. Total of 21 subjects were Fontaine grade 3 and remaining 51 stage 4. 48% of Fontaine, 85% of Fontaine stage 3 and 48% of stage 4 and 52% of diabetic patients were alive without major amputation. The probability of limb survival at 12 months was 72% for all patients, 94% for Fontaine stage 3 and 62% for Fontaine stage 4 and 61% for diabetic patients. The probability of survival at 12 months was 86%. Non-reconstructible critical limb ischemic patients treated with SCS can achieve meaningful clinical outcomes with few procedure-related complications. This is especially more beneficial in Fontaine stage 3. British Journal of Neurosurgery, spinal cord stimulation treatment of peripheral vascular disease, a revival of a promising therapeutic option. A total of 6 randomized controlled trials, a Cochrane review, and a meta-analysis were included. The studies assessed the efficacy of tonic SCS in the treatment of non-reconstructible critical limb ischemia. There is moderate to high quality evidence suggesting that tonic SCS has beneficial effects for patients suffering from non-reconstructible CLA in terms of limb salvage, pain relief, clinical improvement, and quality of life. And they also said that the existing literature provides encouraging clinical results that should not be neglected. Anesthesia analgesia 2022, advances in interventional pain therapies. There is moderate to strong evidence to use a treatment of SCS in treating PDN in lower extremities. Evidence is level 1B+. And also vascular surgery, clinical outcomes in critical limb ischemic patients. All patients before and after spinal cord stimulation were examined in terms of dynamics of their clinical changes using Rutherford scale and transcutaneous oxygen tension. 1 year after therapy, the oxygen tension significantly improves and the adaptive mechanisms of microvasculature were improved in more than 70% of the patients. The positive clinical outcomes were revealed in most patients. The patients with baseline oxygen of less than 10 millimeter can recover if they still have a sufficient microcirculatory reserve capacity. Duration of critical ischemic symptoms and high comorbidity burden with allowance for age are negative factors. Interactive thoracic cardiovascular surgery, spinal cord stimulation for lower limb ischemic treatment. Endovascular approach reduce the number of patients unsuitable for revascularization. However, some patients cannot be treated by angioplasty or open surgery. Some are unfit for surgery, and others have persistent distal ischemia and pain with a functional revascularization. In these cases, SCS is indicated on the basis of more recent evidences. As I said earlier, a trial period with an external stimulator associated with a microcirculatory evaluation is currently utilized to select patients. Surgical Neurology 2000, does autonomic neuropathy influence spinal cord therapy success in diabetic patients with critical limb ischemia? Yes, it does. So it is very important that in those patients with severe autonomic neuropathy, it's better not to do this surgery. Methodist DeBacke cardiovascular surgery, spinal cord stimulation of same chronic limb ischemia. SCS suppresses sympathetic vasoconstriction and pain transmission and decreases vascular resistance and causes release of vasodilatory molecules. When patient is selected based on microcirculatory parameters, it can produce significant pain relief, halt the progression of ulcers, and potentially achieve limb salvage. Pain 2014. In patients with refractory diabetic neuropathic pain, spinal cord stimulation therapy significantly reduces pain and improves quality of life. And finally, this is a very interesting study, is a case report where a case of diabetic type 2 diabetes mellitus, a significant improvement in blood glucose control and significant decrease in insulin requirements after initiation of spinal cord stimulation. Thank you very much.
Thank you, Dr. Ramnarayan, for your excellent presentation. You have taken all of us through your presentation covering the pathogenesis of diabetic painful neuropathy. Number one. Number two, classification of diabetic neuropathy. Third important thing.
Sir, if I may interrupt, can I, before we close it, I have a 1 minute video. Can I finish that before we?
Yes,
fine.
Yes, sir, please proceed.
Yeah, I was just, Snehal, can we have the video in?
Yes, sir. In a minute, sir. Uday, I request you to please start the video.
This video is actually the diagrammatically we are showing the surgery. So initially we will see the trial stimulation, and this is done under local anesthesia. So you'll see the trial electrode being put under local anesthesia, and epidural electrode will be put. Yes, so introducer, we are introducing the trial electrode. We are going up based on level. Usually we keep it at T11, T12 for diabetic neuropathy. For various conditions, we put it at that particular level. This is connected to an external battery. This is placed on the skin. So this is a trial stimulator. So once after 3-4 weeks, we remove the trial stimulator. And then if the patient has got good pain relief, there is definitely benefit from the therapy, we go for the permanent stimulator. Now you can see the permanent stimulator. This is a neurosurgical procedure where you open the skin, do a small laminotomy and introduce the stimulator and fix it to the dura as well as the interspinal ligaments. And the battery also, everything is subcutaneously placed and the battery is subcutaneous. You open the skin, we're going to put the electrode now. Yes, it's called a paddle electrode. Looks like a paddle. Yes, you are putting that and you place it extradurally. You fix it there. We know the site where we need to put because we already done a trial, so we know it. Then we are putting a battery in the subcutaneous pouch. It's inside, and then we connect the wires. Turn on the battery and adjust the current. Thank you. Thank you very much.
Thank you, Dr. Ramnarayan, for an excellent presentation covering the pathogenic aspects of diabetic painful neuropathy, the classification of neuropathy, and the currently available different modalities of treatment with reference to pharmacotherapy, as well as the intrathecal. You have highlighted nicely about the role of morphine and other drugs. And of course, you have covered extensively the spinal cord stimulation, apart from the indications for the deep brain stimulation, as well as other advanced technologies, what you are currently working on it. And of course, spinal cord stimulation, you have highlighted nicely. And even the video also showed the spinal cord stimulation trial. In case if the patient is not satisfied, in case if the patient doesn't get any symptomatic relief with the trial period, and that is not an indication for him to undergo surgery. Am I right?
Yes, you're right. You're absolutely right.
So, so overall, I think it looks minimally invasive surgery that offers
both.
an option for
Both
minimally.
actually. Both actually. The trial is practically non-invasive surgery because we are just like an LP only. We are doing a LP-like thing and putting an epidural catheter. Like this gynecologist for that labor they do. No? Same thing. But the
And
other one is an invasive surgery. The permanent implant
yes,
is
permanent is an invasive one,
yes,
minimally.
yes,
Okay,
yes.
right. And of course, it's an effective treatment of option to those who are not responding to the classical painful management of diabetic neuropathy with the traditional chronic pain therapies, including the opiate medications.
Yes.
And you have clearly furnished the data related to improvement in glycemic control also, when the patient are were given option for the spinal cord stimulation, number one. Second thing is the requirement dose of insulin also came down, number two. Third important thing is the medication what those patients were taking prior to surgery and after surgery. Do you find any difference with reference to the dosage regimen as well as the frequency of administration of those drugs?
Sorry, there's a break in the question. Can you repeat the last question itself?
The thing is, patients already on medications.
Yeah.
Now, the patient has come to you and you have done this spinal cord stimulation.
Yes.
That is permanent.
Yes.
Permanent one.
Yeah, that's right. Okay.
As per the data, there was improvement in A1C.
Yeah.
Improvement in insulin requirement also.
Yes.
My question is
those things I heard. Only the last portion, the question I couldn't hear properly.
Right. The last one is patients already on very high dose of pregabalin or gabapentin or opiate medications.
Yes.
Right. What happened to the dosage for the particular patients, including the frequency of administration?
Actually, we taper the drugs and stop because the patients are coming to us, coming to me rather you are referring the patient to me for surgery because these medicines are not working. Why do you want to continue a medicine which is either not working or causing side effects? So you have to stop.
Okay. And here, to begin with, the earlier days, that is 2012, 2014, like that, they used low frequency. Now you are using high frequency stimulation.
Yes.
Do you find any difference in terms of the efficacy as well as quality of life?
No. See, of course, literature has. I have used. I don't know much about low frequency because I know by the time I have started using it is always high frequency only. But from what the literature says, of course, this I have picked up only very, very minimum literature. I'm sure we have discussed this before. A lot of literature is there, and low frequency acts in a different mechanism. What it does is it produces paresthesia, and that the paresthesia is different to different people. So there is always an ambiguity after the stimulator is put up. But with the high frequency, it is paresthesia independent stimulation. So the standard of the results are always uniform. Obviously, it is better.
And you have clearly mentioned about the indications as well as contraindications for this particular. Of course, no problem at all. Next is long-term follow-up. Did you find any sort of infections?
See, two things are there. One is I have not done so many cases. So obviously, with 2 or 3 cases, if there is no infection, I cannot claim that my results are tremendous. No infection. Whenever there is a saying in general surgery, If somebody doesn't have a complication, either he is lying or he is not doing enough surgeries. That is always a statement made by surgeons. So, because with 2-3 cases, I cannot say. But generally, from the literature, I find that the infection is less than 3%.
So basically, it is directed towards the dorsal root ganglia or the spinal cord.
No, it is directed towards the spinothalamic tract, and that is why it is placed dorsally extradurally. And
Yes,
some
Dr.
amount on the
Akash.
posterior column. Some
Okay.
amount on the posterior column also, because that is why we needed the vibration perception.
Sensations. Yes, alpha, beta,
Yes.
fiber intact function. You
Yes.
made a mention.
Exactly.
Alpha, beta function.
Exactly. So
they are
that's why,
myelinated, of course.
Yes.
Yes, of course.
Yes. Dr. Singh,
Doc-
you are muted. You are
Dr.
muted.
Singh, you are muted and your
So there is
your
a
voice is
question.
not.
There is a question in the chat box. Approximately 30% of patients with DPN experience painful episodes. What is the optimal approach to minimize pain? Anyone, Dr. Patni or Dr. Velu or Dr. Akash?
Yes, sir. Of course, I told during my introductory talk that is glycemic control remains the main cornerstone number one. First of all, we have the modifiable factors as well as non-modifiable factors. Non-modifiable factors, we know the age, duration of diabetes, gender, genetic background. And of course, modifiable factors with reference to glycemic control. Number two, lipid control. Third important thing is cessation of smoking, alcohol. And of course, we have the drug therapy. So we have the guideline recommendations, guideline directed medical therapy, including our RSSDA. They also given their guidelines, recommendations, first line drug. We have the pregabalin, gabapentin, or duloxetine. Of course, as most of the patients, they need dual drug therapy and some they need triple drug therapy. And second line agents, we have the SSNRI or SNRI, like selective norepinephrine reuptake inhibitor, or non-selective like tricyclic antidepressants, amitriptyline, or selective norepinephrine reuptake inhibitors like duloxetine or venlafaxine, like this. Next is we have the third generation, and third line of agents like opioid derivatives or synthetic opioid derivatives, wherein we normally put the patient on. So very important thing is always start with the low dose and gradually increase the dose till we get maximum. For example, pregabalin 75 milligram to begin with, and duloxetine 20 milligram to begin with. Updated after a week to 75 milligram twice daily. And I have tried up to 300 milligram of pregabalin, beyond which I have not gone. Next is regarding the duloxetine, I start with the 20 milligram, 30 milligram. One problem with the duloxetine is excessive vomiting, reduced intake of food, number two. Third important thing is weight gain. And fourth important thing is like glycemic control gets deteriorated with elevated fasting as well as A1C. More so when you combine pregabalin with the duloxetine. These are all limitations. Of course, tricyclic antidepressants, the conventional amitriptyline, we start with the 10 milligram and after take. But one problem is it has adrenergic, next is cholinergic, next is histaminergic. So these pathways are blocked. So naturally we get dryness of the mouth. Next is bladder distension, constipation. Of course, we do come across QTC prolongation also. So we need to balance the good effect as well as the side effects profile of each and every drug. Over a period of time, definitely patient will develop tolerance. So naturally, we need to increase the dose ultimately. And we need to combine combinatorial agents in the management. Ultimately, patient will land up with a state refractory to most of the currently available drugs. That is my experience. Yes, now
I think
Singh
Dr.
and-
Velu,
Yes.
Dr. Ramnarayan told that the 15% of patients usually have intractable diabetic neuropathy, and he also showed in the content in the indication portion that up to more than 5 years, if they had got the similar symptoms, then we can refer for such cases to him. So, Dr. Ramnarayan, so is it okay that
Yeah, that's
patients?
right. Exactly. See, in fact, as we have discussed before, none of my surgeries, the patient should come to me directly. They should have tried all the other techniques, whatever possible. I'm not talking only about diabetic neuropathy. I'm talking about all the other conditions, including movement disorders and all these things. They should have tried for minimum 5 years and exhausted all the options, other options. Then only they should come to me, because multiple reasons. One is mine is a surgical procedure. Second is, unfortunately, as we all know, it's a costly procedure. It's not a simple procedure. And that is why my treatment is only for very highly selected patients. But yes, as you said rightly, there are some patients, and as Dr. Shunmugavelu also said, there are some patients, or rather there is a few number of patients who ultimately will require this. And again, some patients who go to podiatrician, all these people, they keep on reducing. In fact, yesterday I was attending a podiatric meeting here. So many people showed so many healed legs, but all of them are stumps only. And they are talking about preventing amputation. So it was very funny. I was laughing all the time. So there's no point in removing toes and foot and all that, and then claiming that the things are healed. You should preserve. Nowadays,
Dr.
even the
Ramnarayan,
dentist,
yes.
dentists don't pull out tooth nowadays.
So what is the exact cost of this procedure?
It comes to around 15 lakhs.
15 lakhs?
Yes.
Yes.
It's costly. It's very costly.
Yes, Dr. Ramnarayan, one thing that is, patient initially present with the positive symptoms, shock like pain, burning pain, like that.
Yeah.
Ultimately, they land up with the negative symptoms. That is, no symptoms, but reduced thermal sensation, reduced vibration sensation, reduced reflex activity, everything.
Yes.
So one such is vibration, sense of position, passive movement, either reduced or lost.
Yes.
And according to your indications and contraindication for surgery, reduced vibration perception threshold is a contraindication for surgery.
Yes.
That is the main problem. So moving from one of painful, ultimately patient will land up with negative symptoms.
Exactly.
That is yes. That's the main problem.
That is where I am. That is why this point about Dr. Singh saying 5 years, because in 5 years it's very difficult for losing the vibration sense and all that. So what I would, if you ask me for a take home message, what I will say is, keep treating the patient for 4 to 5 years. If the patient is not benefiting with whatever tricks you have in your trade, then don't hesitate to give the option of surgery.
I think this is a very nice message you have given. So I think there is no other, I think everything has been explained. No other question in the chat box. So if there is no questions, I think Dr. Vijay Patni, I will request to him to any question, or then he will conclude.
And now one question is, you are putting the battery.
Yeah.
How often we should recharge the implant battery?
The battery life is usually about 10 to 12 years.
Just like pacemaker.
Yeah.
Same, it's a pacemaker. Practically, it's a different type of pacemaker.
Yeah, Dr. Patni.
Thank you, Dr. Ramchandran, for an excellent kind of input on this extremely difficult the part of a diabetic patient with diabetes, but because it really affects the quality of life and it becomes a hell for that particular patient. But as the epidemiology varies, because I think so, whether it's 15% or 30% who can end up with intractable painful diabetic neuropathy, what is more important is the pharmacological management and the lifestyle management which we employ, probably they are not optimized enough. And the lack of, the reason for that could be because of lack of psychological support. I mean, this is what we know. Okay, even with the minimum kind of dosage, they usually they go off, and they always try to complain of some side effect or other, even with the minimum dose. And probably we usually try to change the medication, pharmacological management. So I think this is very important. Even before we really diagnose it to be intractable, painful diabetic neuropathy, we need to really define the situation in that individual. And most important, I think, before even we plan out a management of painful neuropathy, a good psychological support is extremely important, because this is going to stay with the patient, and probably if a proper counseling is done, then these pharmacological agents can work very well. Obviously, the neuromodulation, which you said, is definitely eye-opener, I would say. It has been propagated, but you showed the video, and that obviously it was quite good and interesting as well. But what would you say about the various things which are said about stem cell therapy for these kind of patients? Any idea?
See, to my knowledge and to my concept, stem cell therapy is a failure for everything except for blood. This thing, but this is India. लोगों को पैसे दो कुछ भी बोल देता है. But one of my own,
some of the literature,
my friend,
one of my
friends, very good friends. So in fact, we did almost our neurosurgery training together. I did it in Bangalore and he did it in Mumbai. He is in running around because he was doing too much cell for autistic patients, and of course he made crores of rupees, and he will spend all that crores of rupees to Kapil Sibal and all that now to get out of jail. So from patients he has taken and given to Kapil Sibal. He's sort of in between person. So stem cell is at the moment. Of course, we cannot say that stem cell is bad. No, at the moment there's a lot of gaps. Lot of gaps.
Only very few studies with very small kind of population where they really came out with even they are saying it is for the research. Obviously, we don't say it is still the recommended kind of therapy.
Yes. At the moment, no.
I think Dr. Velu has already given us an insight into how to manage the patient if he comes with a painful neuropathy.
In fact, just to add one point, if you remember, I showed the ladder.
Yes.
In the ladder,
WHO, 1996.
Yes, the first step, they mentioned over-the-counter OTC medication. That's over-the-counter medications. And they also say psychological therapy.
Absolutely.
So any chronic pain, forget diabetic neuropathy pain, any chronic pain, it's always better to send them for a psychological assessment because, of course, now I'm not very active with all this back pains and neck pains and all that. But previously, when these patients come, you give treatment, send them to a psychologist, and after 1 or 2 sessions, they can even stop the medicine, they won't come back. So psychological management has a big role in pain management. There's no doubt. And your point is, highly taken, not taken, highly taken.
Thank
you. Finally, I would like to say that Dr. Velu, give your take-home message, and Dr. Patni, and then Dr. Akash. I think Dr. Ramnarayan has already given. Yeah.
So despite multiple conservative treatment options, there are considerable unmet needs in the patient population. And of course, we have neuromodulation therapies, including intrathecal drug delivery, as well as spinal cord stimulation. They have the potential to improve pain management outcomes. That is my concluding remarks.
Dr. Patni.
I think we don't have to really go on and on with this. I think Dr. Velu has probably given the right message, and this is actually the take-home message for everyone who is listening, even myself or everyone on the podium as well. So I agree with him. Thank you, Dr. Velu. Thank you.
Can you?
The point which I have to
the
point which I have to state is that type 1 diabetes and type 2 diabetes have different pathophysiologies as far as the diabetic neuropathy is concerned. Type 1 is mainly dysglycemia. Type 2 is a polypathology where you have dysglycemia, obesity, dyslipidemia, hypertension, and various risk factors. So if a patient of diabetic painful neuropathy comes, you have to control not only the dysglycemia, but overall you have to improve the metabolic profile of the patient to effect a proper improvement in the diabetic painful neuropathy. We are also underusing our pharmacotherapy. We are underusing the patients. So as Dr. Velu and Dr. Patni has said that we have to optimize medical therapy. There may be a role of topical agents also for relief of pain, and a psychological support is also mandatory to effect a proper response to the medication which is going on. Despite all these, if the patient does not improve, then the patient should be sent for the further advanced therapies which Dr. Ramchandran has spoken. So this is my take on this.
In fact, I will quote our former minister, Mr. Chidambaram. You try all things. If it fails, mehuna.
Right. One thing we should not forget is that sometimes the vascular element also plays a part, and the vascular factors may come in, and that we may miss out because that may also contribute to the painful stuff. So,
no. In fact, I didn't say. But if you are, I will share with you literature by email or something.
Yeah.
There is actually, compared to other peripheral vascular diseases like atherosclerotic and all that, the vascular surgery doesn't have much role in diabetic neuropathy. Because in diabetic neuropathy, it is more of a microangiopathy. Of course, there may be associated large vessel disease also, but predominantly it's a small vessel disease. And that is why the same surgery is also used for refractory angina, because the same pathology in 10 to 15% of people happens in the heart also. And there also, they have done angiogram, post-procedure angiogram, and showed collateral circulation. And as I said, and just to add one more point, of course, Dr. Velu was saying, in diabetic neuropathy, it's actually initially the diabetic pain, traditionally, original old Davidson used to call it the cry of the dying nerves.
Yes.
That actually the nerves are dying. So if you, just like we in stroke, we remember this umbra, penumbra, and all that. If you are able to get back the vasculature, probably we can achieve 100% success. At the moment, there is no medical management to get back the vascularity.
Again, I think this was an excellent session and something new we have learned from the Dr. Ramnarayan, sir. Thank you very much. Dr. Akash, can you give the vote of thanks? Then the Snehal can wind up.
I thank Dr. Ramnarayan for speaking on a very, very important subject and very relevant subject, and a problem which is largely we are not able to manage in many cases. So he has enlightened us on this, the neurotherapy for diabetic painful neuropathy. I thank him very much for speaking on this topic and for answering all our queries. There was also a very, very intense participation from Dr. Shunmugavelu, who is always a very, very enthusiastic person, and we have always seen him with the tremendous enthusiasm that is very, very sort of infective. And I am sure that all those who are listening get interested, get more enchanted with the sessions which he conducts. So I thank him very much for conducting this session. I also thank Dr. M.K. Singh for conceiving and bringing these CMEs on a very, very regular basis to us on very, very different topics. I thank Dr. Vijay Patni, who is basically the person who is always there to support us, and his opinions are very, very vital to us as his subject, his knowledge on various topics is immense. I thank the USV for providing the platform for these important CMEs, and I hand over the session to Dr. Snehal to conclude it. Thank you very much.
Thank you so much, sir. Thank you so much, Dr. Ramnarayan, sir. It was a fantastic session. We really express our gratitude for simplifying such a complex topic and adding another poll to the CME India series where we keep touch basing upon such interesting topics. So thank you so much to you, sir. Thank you so much, Dr. Shunmugavelu, sir. As usual, your clinical insights which you've shared are like the cherry on the cake to every session. So thank you very much, sir. Nonetheless, thank you so much, Dr. Vijay Patni, sir, Dr. Akash Singh, sir, for your continued support for making each and every event a successful one. And last but not the least, Dr. N.K. Singh, sir, for putting together such fantastic sessions so that our audiences are continuously engaged. And we really look forward to more such interesting sessions with amazing topics with such an eminent faculties in the near future. A very heartfelt thank to all the faculties today on behalf of the entire USP team. Thank you very much.
Thank you all. Thank you. Good night.
Thank
Good
you,
night.
NK. Thank you,
Thank you.
Snehal,
Thank you, sir.
and Snakyo,
Thank
Patni,
you.
Singh, and Ramnarayan. Okay.
Thank you.
Thank you. Good night.
Thank you.